All right, I think we could go ahead and get started. This is going to be an interactive session, so I totally appreciate you guys sitting over here because you can see the screen, which is okay. There's not going to be tons and tons of screen content. A lot of what we're going to do is get into kind of conversation. So there is a microphone in the middle, and if you have some questions, feel free to kind of just wander over to the middle. I'll figure out that you got a question, and we can do that way. It's also going to be really interactive with the panelists, so we're going to go ahead and get started. My name is Courtney, and we're going to talk about interview skills and how particularly to ask the right questions to understand how to get the right job, the right fit for you for your career. So these are the objectives we're going to tackle. We're going to evaluate the fit of a potential job with your career goals. We're going to discuss what not to do in an interview setting and why, and then we're going to also give you some examples of what to do, how to ask the right questions to figure out some of the answers to things here. And then we'll talk a little bit about strategies to drive the interview and summarize some information. My name is Courtney. I'm at Northwestern. I'm the Director of Research there. Deb Diercks also helped me plan this meeting. She is the chair at University of Texas Southwestern. And then I have also invited some members of the Industry Advisory Council of SAEM to talk as well, who represent both the academic and also the community side of things. So we'll talk a little bit more about the Industry Advisory Council in a moment, but I'm making some assumptions that all of you are looking for well-being in your career, and also that starts with the type of job you have. There's individual factors of well-being or burnout, and one of the biggest drivers of the individual factors is made at the time that you choose your job. Who you work with, where you work, to some extent finances and dollars, although we're going to de-emphasize and really not talk about that in this context. We're going to focus a lot on the other aspects of how to figure out, is this the right job for you? We're not going to talk about academics versus community. We're not going to fight about that. We're going to just assume that there's a wide spectrum of jobs, and finding the right one for you is key. The Industry Advisory Council is an entity that is part of SAEM. It was set up about a year ago with the idea of bringing some members from contract management groups, physician staffing groups, who are interested in having a collaboration with SAEM to think about some of the challenging topics on the future of emergency medicine at large. We understand that half of our members at SAEM are residents. We understand that not all of those residents end up in a pure academic job. And we also realize that there's a lot of hybrid jobs that are kind of in between, where maybe you're at a community site, but you are supervising residents to some extent. So the Industry Advisory Council members are here. One of the things we did is we created this thing, which if you Google Industry Advisory Council or 13 questions on SAEM, you'll find this, and you can refer to this. There are 13 questions that we thought were really important for you to ask to find the right fit for the right job for you. So I'd encourage you to look at it now. We're going to go through a bunch of these questions and use that as a resource to look at again. The Industry Advisory Council, and I'll introduce the names of these individuals, but the organizations that they are representing is U.S. Acute Care Solutions, EM Recruits, Apollo MD, Leading Edge Medical Associates, Envision, Integrative Emergency Services, and American Physician Partners. Not all of the folks on the industry advisory groups are here. We've gotten 3 of them here, and we're gonna. But this is a collaborative effort. So we're going to dive into 6 of these questions that cover 4 domains. Non-clinical engagement. What am I doing outside of just seeing patients? Volume, acuity, and staffing. How do I figure out if that's what I'm up for? Performance evaluation. Like, how do I know if I'm doing good or bad? And then what are the main points of, kind of pain points of the clinical setting? What do you need to kind of ask about to know about, the kind of negatives of a potential job? Because nothing's perfect. So each one of these speakers is going to have about 10 minutes to kind of go through that. I'm the moderator, and what we're going to do is we're going to talk about how not to ask the question, and then we're going to talk about how to correctly ask that question to get the right, rich information. And then we'll have a little bit of Q&A too. So, you have an interview, and this is really pretty typical. The interviewer, you've talked about a bunch of stuff, and then the interviewer says, so, do you have any other questions for me? And now that's your chance to kind of get some information, right? So we're going to role play this. I'm going to be the role of the interviewer. These guys are going to be applicants, and they're going to flip between good examples and bad examples of how to do that. So first here, you want to try to learn about the non-clinical expectations. What am I signing up for other than just seeing patients? So Deb Diercks, UT Southwestern, is going to be the role of the applicant. So, Dr. Diercks, Do you have any other questions that you'd like to ask about this job?
You know, I'm interested in education and... Right?
Yep.
All right. Better?
Got
Awesome.
it.
All right. So I'm really interested in education, and how much protected time are you going to give me so I can, you know, do that?
Oh, the dreaded protected time. Nothing. No. Bad question.
Well, you know, if you're not going to be protected time, then all I have to do is show up for my shifts, right? Clock in, clock out?
No, that's not what we're looking for.
Jeez. Huh, let me think of another one. Do I have to go to other meetings?
No, that's not really very good engagement.
So, all right, let's say, so you're not going to protect my time, and you're going to make me go to meetings. What if 5 to 10 years, I don't want to work clinically anymore?
No, not a good question.
Oh, this is really hard. You're not really helping me. So, I look around, and there's a lot of people who've been here a long time, and all of them have, like, titles. So is that what it takes to get a title around here? You have to be here forever?
Nope. So we're going to flip the script now, and we're going to try again. All right, Dr. Diercks, how can we, we're really interested in this fit, you know, this, we're interested in your candidacy for this position. Do you have any other questions about this job?
You know, I'm really interested in education, and if I start doing something that the department finds valuable, is there an opportunity to have, you know, to balance my clinical shifts with that kind of work?
Okay, that's good. All right, any other questions?
You know, I realize that being part of a department means there's other things to do. Are there other opportunities for me to get engaged, you know, as far as outside my shifts?
Yeah, for sure. So this is a great way to try to figure out how are your values aligned with the department's values. This is the beginning point of trying to figure that out. What does this person who is hiring you the chair want or need, independent of just seeing patients, and how does that fit with what you want and need? So this is your chance to try to figure that out. Any other questions?
You know, I like operations, and I think in the future I really would like to be interested in operations. What's the leadership development, and is there a plan to kind of develop people into that role over time?
Yep, that's a great. So who is she going to be mentored by? Who can she learn from? What are those opportunities? Where are some operations challenges that the department's struggling that might be a nice fit? Okay, good. Anything else?
You know, being engaged is important. Are there any committees or any didactic to residency opportunities that I'll need to go to during my time?
Yeah, absolutely. We can talk about what some of the needs are right now. We can think about, I've looked at your CV. I've identified that you're interested in coagulation. So, you know, it's a small step, but maybe serving on the hospital transfusion committee would get you exposed to some other potential leaders in the hospital system, and would also help us and be good to kind of put down on your CV, because we're trying to think about how you're going to grow and ultimately get promoted. All right. So pretty good. I'm going to just see if anyone has any questions about how to try to ask the question or interpret this tough thing, which is, how do I know what I'm getting into from the standpoint of what else is there in academics or not in academics other than just seeing patients? Because that is an important part to your overall fulfillment. I'm going to let the panel comment on this and just give some examples or some thoughts if there's no questions at the mic before we move on to the next question.
So I would go step way forward and just look at, let's say you do want to do some non-clinical work in a group, academic or non-academic. Now, let's put yourself in the position of the person who's going to decide whether you're going to get that position or not. There's 14 clinical docs. Everybody wants to be a medical director. What are we going to be looking for? What's going to put you in the position to get that leadership position, right? So what do you think they're looking for? I mean, think about it right now. What do you think they're looking for? They're looking for somebody who's professional, who treats patients really well, who's a super hard worker, who's going to work really, really hard regardless of whether they get paid for it or not on extra activity. And so those are kind of going to set the stage of whether you're going to progress in this non-clinical role. So these are great questions to ask. The way she's asking that, how can I be involved? What can I do to help the group? What can I do to add to my worth in this group? And don't ask about the money, how you're going to get paid for it, what that responsibility is. Hopefully they're going to be fair. If they're not, you're going to figure that out. But so I like the way these questions are asked, and you just think about it from that standpoint to put yourself in that position for leadership in the future.
Craig Meek will introduce later from Leading Edge Medical Associates. Nick Zinarosa.
Every group is trying to make themselves more valuable to the hospital, and so this is a great way for the physicians in a group to add intrinsic value of that group to the hospital, to what Craig was saying. Whether it's a third-party contract management group or a hospital-employed model, this would add value for your department, at least to the hospital. And like Craig said, release that ship nicely for future leadership. We were just joking before the room filled up, that you know, it's not unusual when you start showing them to committees. Suddenly, since you show up, you are now the chairman. So it'd be very beneficial down the road.
Travis Ulmer.
Yeah, I would completely agree with that. I think it's good to recognize that the director has a lot of different people that they're responsible for, and unfortunately a lot of complaints come to them. So when you can show up and provide something of value and help take some of those complaints off their plate, that's something that's very, very enticing to the director.
So I think there's always a balance about what your mentors may be telling you to ask for, and what you see your mentors get, and what you get when you're day one out of residency. Coming in, we've got a bunch of people who are all asking for the same thing, right? They all want to be promoted, they all want development, they all want time, and they all want money. So when you come in and you're asking and you're trying to look for a job, trying to find that information out without coming across entitled goes a long way. So you may want a title when you come in, but asking for a title, and believe me, I've had people ask for titles, figuring out what you're going to do and how you're going to get there and how you're going to get the job done and the skills for the jobs is much more palatable discussion than somebody saying, well, I want to be an assistant medical director. If I come in, can I have that title? Well, I don't know what you know. So the answer is no. And I think really just being mindful that time and money are things that aren't unlimited, and everyone's got to balance it. So really showing that you're willing to work for it, you're much more likely to get what you're asking for.
So this is how it's phrased on the website, number 4 of the 13 questions. Other than direct clinical service, what are other expectations and opportunities either now or as a new hire or as I mature in the group? How are these supported or decided upon? And then some domains to think about. So that's a reasonable place to start. We're going to move on to the next one, but I'm also going to say that the other way to try to get at this is to talk to other people at the group. Hey, you're going to interview with multiple people. You're going to talk informally and formally with other people. What are they doing? What has their trajectory been like? What did they do in the first 1 to 2 years, and then what are they doing now? And how has that been rewarding to them? So it's not just the person that you're asking. Yeah, go ahead.
I just wanted to ask whether you would just each introduce yourself once again and say where you are, just because that will help us understand whether you're coming from a more academic perspective or a community perspective.
You bet. And there's a little bit of some hybrid. So Deb, we'll go across the room here.
I'm Deb Diercks. I'm Chair of Emergency Medicine at UT Southwestern, so I'm academic.
Nick Zinarosa, I'm the physician leader for Integrated Emergency Services in Texas. We service a couple large healthcare systems.
I'm Craig Meek with Leading Edge Medical Associates, which is in Texas, and I think you're a true leader, whoever asked that question. I really appreciate you doing that because we forgot to introduce ourselves. Thank you.
Travis Ulmer, I'm one of the vice presidents with U.S. Acute Care Solutions in Columbus, Ohio, and work both academic and community centers.
Yeah, and it is an interesting point. When I was a resident, I thought that there was just complete black and white academic versus non-academic. There is, without a doubt, a movement in emergency medicine and in a lot of different areas where some of the large contract management groups, like, for instance, U.S. Acute Care Solutions, have residencies. And, it's not necessarily as black and white as you may think that it is. So we're talking a little bit about both. I think the way you go about some of these questions, though, is a lot different if you are looking at a research trajectory, or your career plan is, I want to be a program director someday. okay. The questions that you ask and is a little bit different. Still, these are important bread and butter things. So we're going to move on to Travis Ulmer. Number 6 on this is you're trying to figure out how busy it is. I mean, it doesn't matter, academics or not. Like, if you're going somewhere that's going to just be busy as can be, you kind of got to know that. You got to think about that because you may or may not be happy regardless of what setting you're in. So, Dr. Ulmer, I know you're interested in this job. We've talked a lot. Do you have any other questions?
Yeah, no, I really appreciate it. What's your name again?
I'm Dr. Courtney.
Okay, yeah. So I really hate night shifts. How bad are they?
That's really not a good question. Everyone's got to work night shifts. Yeah, boom, next question.
So do you guys have to deal with boarding patients?
Not a good question at all either. Not a good question.
Do I have to work with the providers that will see the patients aren't sick for me? I don't know what they're called.
PAs? That's really not the way PAs are supposed to work. Nurse practitioners? No, not really. Not a good question.
I guess last, if it gets busy, do I just call you to help me, or?
No. We have an emergency backup system. It's only for true absolute emergencies. Like, you got to have your appendix taken out, and then we'll call someone in for you.
How's this going for me?
You're not going to
succeed.
Good. You're not going to succeed. So, all right. So not. It's a really good question. So how can we ask that question? So, Dr. Ulmer, do you have any other questions that I might be able to answer?
Yeah, so I want to be a part of the group and help with night shifts, obviously. That's part of our role. Are there any different services that change, maybe ultrasound ability or consults at night, or even the footprint of the ED that I need to be aware of? Yeah,
super good question. I mean, it proves he knows what the game is like. He understands that he could be in a tight spot if he doesn't have X, Y, and Z available at nighttime. So that's a good question.
In talking about nights, how does the night team typically do? Is it usual to be able to clear the waiting room by morning?
Super good question. Another good question would be like, are you expected to stay 1 or 2 or 3 or 4 or plus hours to, quote, clean up all of your patients? Like, there's a little bit of group culture. And it's also going to vary by hospital, right? These guys are representing multiple hospitals, all of them. And so it might be different at Hospital X in State Y versus Hospital A in State B.
Obviously, boarding is an issue nationwide. How does the current group address that? Are there any active plans that you're using today to address it?
Yeah, super tough question. I mean, that's putting me on the spot. Like, I now have to articulate what have I done to interact with the hospital at large with boarding and bed capacity. So, like, I should have an answer for that.
How are the APPs integrated into the overall care of the patients? Do they have an independent scope of practice or even a defined scope of practice?
Yeah, super really good question. So this is a really hot topic right now. We don't do a good job of training you guys as residents on how you are ultimately going to supervise PAs and NPs. I mean, we're kind of referring to them as APPs or advanced practice providers as opposed to like mid-levels. But yeah, like this is a really important question. Are you just signing off on 20, 30, 40 people that you never had a chance to hear about or see? Maybe that's going to result in a little bit of angst, and maybe it should. And maybe we as a field need to think a little bit about that. A really important question.
Just so I get a better feel of the overall flow of the department, can you talk to me about the annual volume, perhaps even admission rates, ICU rates, and any certain particular set of patients that you're a center of excellence for?
Yeah, so I mean, you can talk about annual volume. That's going to depend on acuity. I mean, if you're seeing a lot of volume but they're not that sick, then maybe it means something different than if they are. So I can tell you that 20% of the patients get admitted. I can tell you that 3 to 5% get admitted to an ICU. I can tell you that, we are a stroke referral center. And so, we're painting a picture of what you're getting into.
And then my final question is, do you have any strategies for unexpected surges or when the wait times are getting overwhelming for the department?
I wish I did. Yeah, no, sure, absolutely. This is a universal challenge and problem, and so groups that have good leadership on the physician side and the nursing side and the admin side are going to have some ways to answer that question. No one solved it, but a good question. Good, all right. Any questions from the field at all on this topic? Good, okay. Any panelist kind of comments on how to think this through if you are on the receiving end of this question?
I mean, this is the key question. So you all should probably have a list of these that you go into the interview with, right? Because your clinical environment really does impact your wellness. And understanding what you're getting into, understanding how the group handles it, understanding how innovative the group is when dealing with it, those are all things that long-term you've got to know, and you really hope you can get a sense of it when you interview. And so I think that although these seem like trite questions, they're kind of key to your clinical environment and are probably the most important thing, because a bad clinical environment is just tough.
So one thing to consider is to get an idea. I'm not sure how you would do this with these type of questions. Has there been a shift in hours of coverage from physician to APP, and why has there been a shift? Sometimes it's because there's been a payer mix deterioration, and so they're trying to have the doctors be responsible for more patients in a given period of time to maintain their the income, right? And so, to what Mark was saying a second ago, it would not be uncommon if all of a sudden you see a payer mix deterioration where you used to be able to make a certain amount of money at 2 patients per hour. Now, to maintain that same level of income, you might have to be responsible for seeing 4 or 5 patients per hour. And the only way to really do that is if now you start incorporating APPs into your practice so you can oversee that care and get some compensation from it. That's one strategy some groups may utilize.
Craig?
Yeah, so what Nick's saying, I would, if I were a resident about to interview, my first comment would be is you're going to work with APPs. And there's no way around it. You're going to be signing off. You're going to be working with them. So if you're concerned about that, or I think you need to learn how to do it, but I would just kind of take that as something that's going to happen in the future. My second comment is this is very difficult because, let's dumb this down. You want a job offer in this interview, and you want to find out if the job is really brutal. So how do you come across and ask these questions? Is this a brutal job, but still look like a super hard worker that doesn't care if it's a brutal job, right? So I want the job offer. So these are tricky questions, and I think that understanding metrics and data on patients per hour, acuity, and those kinds of numbers that are thrown around. When I was a resident, I didn't understand any of that, really. But understand how that's being done is going to be helpful in comparison to jobs. But it is difficult because you have to ask these hard questions. But then you also have to come across, I'm ready to go, I'm ready to work for you, I'm ready to turn patients, I'm ready to take, I want this, I'm ready to make your group stronger, but you also have to ask these hard questions. So I think it is a difficult situation.
And the last piece of advice I'd give is you can also ask to do a shadow shift. That's how you can actually visualize the flow of the department. You can really see what the issues are, and you get a truer answer that way. So that's something that I highly recommend to a lot of new grads.
Yeah, those are really good points. Another, just because we have a little bit of time, and I just kind of want to also disseminate some information to y'all, but this topic of PAs and NPs in emergency medicine is really being discussed at top levels. So I am just now rotating off the SAM board, and one of the things that I got appointed to do is serve as the SAM liaison to a group, a task force of all the different organizations in emergency medicine. It's being led by ACEP, but it's all of us kind of together talking about what does the future look like for workforce needs and workforce demands. And it's a really kind of tricky thing to think about, but it's really pivotal to your guys' future because we don't really have a good answer yet as to how many emergency doctors are needed 10, 20, 30, 40 years from now. We know that the market is tight in certain places where people want great jobs. You want to go and make a ton of money in San Francisco? Like, good luck. That's a tight market. We also know that there's tons and tons of need in places, and in some situations in rural places in the United States, they're still unable to staff a board-certified emergency doctor. So finding the balance and trying to think about where the future is headed is a really tough topic. I know as part of that process, there's going to be a survey sent to graduating residents as soon as, I think, June, July. I'd encourage you to fill out that survey because we're trying to get some information as to what types of jobs this current cohort is headed towards. And that's going to be the beginning of the modeling to try to think about this answer. So I don't have the data yet now. It may be as soon as October, November, December that there will be the beginnings of that information that I think is going to be really important, not just for leaders, but for residents as well. All right, we're going to explore the third domain here, which is related. This is what is the role of APPs in this group, both at large locally or where I will work. What are the expectations with respect to supervision and acuity? We didn't really talk about supervision, but that's also a tough topic. Like, are you expected to sign charts? Are they billing under their own provider number and code, which generates less revenue for the group, but you know, might protect you a little bit on your side? This is an important question. It's not, so it's kind of related to the last question, which is why it follows here. We're not going to do a deep dive on that, but it is on number 8 on the website, list of 13 questions. So this is now the next one. We're going to have Dr. Nick Zinarosa, CEO of Integrative Emergency Services, answer this one. So number 13, we're trying to explore here basically how you're evaluated. You know, what happens if you're not meeting expectations. So Dr. Zinarosa, make sure your mic's on too.
Hello.
Is it on? Yeah, we're good? All right, so Dr. Zinarosa, talked a lot, you got a lot of talent. We're trying to find out if this is a good fit for us, for you. Do you have any other questions about this job?
Well, you know, Mark, we all know time is money.
It's Dr. Courtney at this point.
Oh, I'm sorry, Dr. Courtney. Time is money, and if I'm slow, do I get fired?
Oh, well, I mean, that depends on how slow are you. I mean, are we talking tortoise-like or, you know, no, not good question, not good question.
And, you know, Mark, we all know patients can be sick. If I've got a bad outcome, do I get fired?
I don't know. I mean, are you Black Cloud? I mean, are you known for having horrible bad outcomes? Like, maybe I need to check into that.
So these are actual questions. And, Mark, you know, I hate to stay after my shift, especially if it's been a busy shift. And, you know, everyone knows how clunky EHRs are. So, you know, the hospital regulations I looked up say I can finish my charts within 30 days. Is that a problem?
Oh, God, no. We can't have open charts for 30 days. Plus, if you can't do them in 30 days, you're not going to get them in 31 or 32 or 60. I mean, you're going to have, you know, no dice. This is not going well.
So, another way to ask some questions about performance would be maybe something along the lines, you know, I always look to improve my practice and provide the most beneficial and efficient care to my patients. By what measures do you guys measure both quality and efficiency in the department? And if I happen to fall below these measures, are there feedback mechanisms and resources available to me that I can improve and get better?
Yeah, so this is a really key question. I mean, you don't have, it's hard for you to graduate and know how fast you are. I mean, you might have an idea, you might be able to compare yourself to your peers. I've always taught my residents that you kind of want to be in the middle. You don't want to be the fastest, worst charter, worst documenter, quickest in the room, but you don't really want to be the slowest either. You kind of want to be in the middle, you know? And it is burdensome to have to fill out the chart. And the academic environment, especially if you're supervising other interns or second years, you know, it may not be the same as if you're on your own. So the idea of how you are going to be evaluated in the future based on, you know, clinical metrics is a really interesting, tough one to kind of think through, in part because you just don't have that experience yet, and but you really need to know what you're getting into and maybe what the expectations are. So let's see if the panel has some additional suggestions on how to dive into that. And they may also share with us how they evaluate their clinicians, how if something is coming up that's a problem point, there is feedback or there is a remediation or there is ways to address it. Because the amount of money it takes to hire a new doctor, credential, onboard, train, integrate, that amount of money is not a trivial amount of money. They do not want turnover. They do not want to lose someone that they've hired. How much money is it?
I'd say about $20,000. I'm just guessing.
So when we looked at it, considering how long it also takes to onboard somebody and the decreased productivity in the first few months, it can be anywhere from about 50 to 75 from our estimates.
Probably no right answer, but I mean, they're in it and you're in it to succeed. And how that looks is best facilitated by knowing what you're getting into. How else could they ask some questions to try to dive into this? Or how else do you guys on your end, how do you address performance and feedback?
Yeah, I think first off, just saying that, you know, I'm really interested in getting feedback in my career. You know, I want to be the best doctor I can be. So can you tell me about how you guys provide that in your group, right? It shows that you're open to feedback and you want to get better, and that's a good position to be in as a candidate.
Dr. Diercks, from the academic side, you're going to have to give feedback not just on clinical performance or how kind of fast patients are being seen. You're going to have to give feedback on a lot of other things. Is there a formal and informal? Is it once a year? Like, you know, how are faculty evaluated? And does it vary based on whether they're pure clinical faculty or a little bit more on a focused kind of scholarly trajectory?
You know, so from an academic world, we're kind of, the institutions define how often we have to evaluate people, so our faculty get evaluated once a year formally. The clinical stuff, we actually give our providers monthly feedback on patients per hour, RVUs per hour, patient satisfaction, and actually give them a comparator to where they are to the entire group. So they have a monthly dashboard on where they are, and then whether they're meeting the other department metrics on attendance and stuff monthly. But I think the key word is feedback. I mean, feedback is an awesome word. It puts no one on defense because you're asking for more information. So I think that's a really key word when you interview, because it's not, there's no negative connotation about it. None. It's you asking for help. And I think that really goes a long way to the employer.
You know, it is not true that no news is good news, right? And so you want constant communication, like Deb was saying. We built out some pretty extensive dashboards. If you look at most of what is measured, you got flow metrics and you have outcome metrics. And so those are two things that our providers see on a regular basis, and then we do review it monthly at the site director meetings.
I mean, I would just say about feedback that it's going to happen at every job. We have tremendous amount of feedback for ours, and I think that every human by nature does not want to get feedback because there's going to be negative feedback, and that means I'm going to have to change, I'm going to have to evaluate that. So by embracing it in the interview with this question, saying, help me get better, I want feedback, you're showing a strong amount of courage, you're showing a strong amount of just self-actualization. I think it would make me want to hire you, really. So.
Yeah, real quickly, too, if future leaders, you know, if someone is ever surprised when they do get fired, then you probably have not done a good job of being a leader because you didn't give enough feedback to let them know how they were doing at certain points of that process.
I think that's the question is, from an academic position also, are you aware of what the expectations are? Right? So it's great to get feedback, but if you're getting feedback and you don't even know what you're aiming for, I think it's really difficult. So it is, I think it's acceptable to say, what are your expectations? Mm-hmm. You know, for academics, for scholarly work, for clinical time, for clinical productivity. That's a reasonable question.
Yeah, and I would say it's going to be very common across the industry that you're going to get quantitative data on where you stand in terms of patients per hour, throughput, and also, you know, how many CTs, CBCs, et cetera, that you order. So embrace that. There is a push across the industry to reduce variability. And show your openness to discuss that with your director.
Yep. Yeah, and another thing we're talking about within the Industry Advisory Council is, and also RAMS, the Resident Medical Student Board, is a project for next year where we may consider trying to think about a template that we could provide to residents to begin the process of describing what their career trajectory looks like. A worksheet, if you will, to kind of begin to fill out kind of how you decide, what am I looking for, what am I shooting for, what am I aiming for, to kind of get at Deb's point, which is, you know, feedback's fine, but you need to know, and both people ideally, the hirer and the hiree need to be in sync and have those aligned.
Mark, can I say
yep.
one thing I just want to add on? One of the most I guess, feedback mechanisms we do that people are unaware of is we do a 360 nursing survey on all of our doctors, and the new residents, the new hires know they're being tracked on a lot of data where we talked about metrics and CT scans and all that stuff, and the feedback is obviously, let's try to get you within the norm. But I think the shocking thing is when you get nursing surveys that say, you know, he's kind of rude or he doesn't listen and those kinds of things. So that feedback is probably the most valuable and actually does the most to change people. And it's really, really helpful. But be aware that that could be a mechanism in the jobs you take.
Good point. Good point. All right. So This is kind of the last domain that we're going to dive into. What we're really trying to get at here is what are the things that most lead to frustration in the day-to-day aspects of the job, and what's being done to address them. So no job is really perfect. Yeah, we'll go ahead and entertain a question because we've got plenty of time. Thanks.
Hi, my name's Rebecca. I'm from the University of Massachusetts, one of the residents there. I was just wondering if you could address how to ask about the culture of the group and the physician interactions, and how you address, is this kind of a nice place to work or malignant, and what the best way to ask that would be in an interview.
I mean, there's a couple ways to go. One is the turnover. Yeah. If people really hate their job, they leave. Right. So really, what's your turnover rate? How long have people stayed? Are you hiring because of growth, or are you hiring for replacement? That's another way to get through to it without asking it directly. And then it really is what kind of, individual development that you have, or faculty development, provider development out there. That gives you an idea whether they're invested in improvement, and in kind of long-term growth.
Yeah, I think in the academic sites, the gatherings and socials and stuff are inherent with the residencies. But at the community sites, that may not exist. And so I think asking about, are there any events or annual things that you all do to come together as a group is another way to kind of find out if they like to see each other outside of the hospital.
I think you're asking a great question, and I'm going to dig into your question a little bit. You're asking about culture. You're really asking about the people. So you're asking, how do I know that these people have good character and they're positive and they're nice people to be around, and that I want to work around them, right? So that's really the question. And actually, that's the thing that I see residents never ask about and never evaluate. And it's very difficult to ask a question to somebody in an interview to understand, are these people I want to work with, and call my partners and have them see my bounce backs. So I think the way you do that is you meet as many people in that group, your future partners, as possible in that interview process, and not just the ones they want you to meet. And that's hard to do. Some people go out of their way to do that, but try to meet and shake their hands and talk to them about their interests and stuff like that, and you'll start to see this is a culture of people that have my ideals and believe what I believe and are positive, and they seem to be happy and those kinds of things. But I think you're asking a great question. I think you're asking probably the most important question in an interview. It's just hard to ask in an interview is what I...
Yeah, I agree. And, the shadowing shift is a good opportunity to really witness the culture. And then the other thing I would mention is, especially if you're going to go to a community center, in residency, you're staffing every patient, you're talking to other clinicians constantly. In the academic world, the only time you talk to other physicians may be on the phone with a consult. So really, you're going to be working mostly with the ancillary staff. So really, you want to get to know and meet, the nursing leader and some of the other staff, because that's who most of your interaction is going to be with throughout the day.
So to Craig's question, you might want to ask how many of their attendings have a picture in the post office. I mean, that'd be one way to do it. You might want to ask things, because turnover rate can be misleading. You don't really know how they're calculated sometimes, or retention rates. So you might want to ask things like, which doc has worked here the longest and how many years? Probably if you're going to go interview for a job, they should take you to some sort of social event where you're going to meet other people in the group, and you kind of see how they all interact with each other if they're complete strangers. Very different than if they know each other's kids' names and things like that. I'd ask if anyone serves on mission trips or volunteerism, things such as that, to kind of give you a different idea of what they're doing outside of work, too.
Do you think there's differences, and you could tell anything from how sick call or emergency illnesses is handled? If you could ask about that on how your group handles it, it may give an idea of how much they pitch in for each other.
Thank you so much.
She said sick call. If you ask the question of how the group handles sick call or emergency call in disasters, or you could add paternity, maternity time. I mean, some of those things too.
Yeah, that's interesting. I can see sitting in the director role, I could probably flip that to however I want to make it appear well.
Yeah.
Hey, we don't have one because we don't need one.
Yeah.
Everyone pitches in. Or, yeah, we actually have one, but in the back of my head is like, we had to have one because I was pulling my hair out because nobody would come in.
Yeah.
So it's a great question, whoever brought that up.
Yeah, it's really good. So I like to try to think a little bit about wellness and burnout in terms of some models, right? And one of the models is to try to think about where the different factors act, right? So when I set this talk up, I mentioned that the individual factors you have some control over: where you work, who you work with, salary, dollars, hours, and the second unit is the work unit. Like, what are the pain points of this emergency department in terms of boarding or crowding or whatever? The third unit is the organizational level, right? And culture and mission is really important in that. And then the fourth are national factors, right? And so there's a whole matrix of what different drivers of either burnout or drivers of wellness and well-being and engagement are across that kind of matrix. Tate Shanafeld, 2017, wrote a great paper that you all should probably look at that has that laid out, and it's probably the single best thing to read about a model of burnout or well-being that's worth checking out. It's called Executive Leadership and Well-Being in Medicine. I think that's the general title. So we're gonna dive into that a little bit, because we're gonna talk about some of those clinical work unit potential pain points, things that might really suck at a job, or things that might be great and might really, really, really attract you to this particular job. So the last role-playing applicant, Craig Meek here, is the Director of Communication and External Affairs. That is the longest title of anyone on the panel.
I tried to have the longest title. That's really important to me.
Yep, and of Leading Edge Medical Associates. So, Dr. Meek, I understand that you are looking for this job. We've had a nice time talking. Do you have any other questions for us?
You know, Dr. Courtney, I really hate drug seekers. Are you guys just giving a bunch of narcotics? I mean, what are you guys doing here?
Oh, no, that's a terrible question. We've solved that problem. Yeah, we're a pain-free ED. Nobody comes. This is not an issue. Everything's great.
Okay. I just have one question. You know, I just, surgeons, man, there's this guy I work with in my residency, and I just want to rip his freaking lungs out. He's just, do you have problems like these consultants? You just, like, what do you do?
Oh, this is not a good question at all. Not a good question.
All right. Tell me about writing orders for people upstairs. Am I going to have to do that?
Yeah, no, not a good question. But an important question, kind of. We'll get into that. Carry on.
Can I just send my psych patients somewhere else? Do you guys have some place we can send them?
Yeah, we do. We've got a magical unicorn that takes them all away instantly.
And what about old people? I mean, are we having to put them all in the hospital to get them in the nursing home? What do you guys do?
You look kind of old yourself.
I am.
All right, so let's flip the switch here. Now, the interesting thing is on the website, we address this with a kind of a ridiculous question, which would be like, rank the following things in order of what causes the most frustration in day-to-day work in this particular practice setting: interaction with consultants, boarding, ED crowding, patients presenting with substance behavioral health challenges. You would never go through this laundry list of stuff. Like, that's a terrible example. So we probably shouldn't have written it that way. So I've crossed it out, but they're all pretty important things to dive into. How could we do that in a better way? So Dr. Meek, if you're interested in this job, do you have any other follow-up questions about the difficult aspects of the practice environment here?
Man, I think you guys have a great model here and a great group. I'm excited about working with you guys. Now tell me, when you guys get done with a shift, what is the most stressful thing that you have to deal with that shift, that you have trouble when you leave? Tell me a little bit about that.
Yeah, so this could be, I mean, this is a great question, right? I mean, there's no right answer. I'm looking for some honesty, you know what I mean, from this. So if like somebody says, no, everything's rosy, everything's great, yeah, you got to kind of wonder about that. It gets to also the point of like, go talk to some other people, spend some time in the emergency department. Sure, we have problems with boarding. This is the average time from, bed order to the patient going upstairs. This is what we've done to work that through in terms of orders and in terms of who's responsible for, the care. Like, there's a lot of ways to answer that, but it's a really important question. Any other questions?
Yeah. This is an awesome group. I'm really happy you guys had me come out, and I'm so thankful for the opportunity. There's some national issues that I see, even my residency, I've seen interviewing around, that I'm just kind of curious how you address, like psychiatric care and having to hold on to those patients, and the narcotic abuse problem that we have in America, and just complex geriatric patients. And tell me a little bit about how you're addressing these issues, because they're difficult across the board. And what mechanism do we have to kind of help implement change to make our whole group better when I work here?
Yeah, so I mean, we have a social worker who's dedicated to the emergency department. We have on-call, phone call ability to interact with a social worker. We've got these protocols developed to try to manage some of these challenges. Like, who knows? There's different solutions at different practice settings, but this is a good question. Okay.
Tell me what data-driven or outcome-driven mechanisms you have that we can implement change here in our group to make this place better.
Yeah, so this is a great question, right? I mean, to what degree is leadership invested in quality improvement initiatives? To what degree are those integrated in the hospital system? How much buy-in is there from the hospital system for quality improvement changes? And is that really something that matters to patients? Is it coupled with patient care? Is it something that people just do for the sake of doing, or is everyone bought in, including nursing leadership as well? Whether that's CT ordering, whether that is metrics associated with time to admission. There's a variety of these. I know, Nick, you've investigated some of these as well. That's a good question. Well, should we open it up to the rest of the whole panel to kind of chip in on that one? So, yeah, again, we're trying to get at how do you ask about what some of the challenges are and how do you get a good, honest answer? Sure.
You know, a lot of these issues that you bring up really reflect how well the department's managed and led within the hospital. And there are times when if you have a weak medical director, the department themselves just has learned helplessness, that they're just a recipient and this is the way it is here, and you're going to put up with boarding whether you like it or not, or you're going to put up with psych patients being held. And you kind of want to tease out how much of an advocate for the emergency medicine staff that medical director is, and what are they doing within the hospital culture, and to really, push forward some of our initiatives to decrease, negative interactions with consultants. Because what will happen, the ones you interact with are the ones who the administrators perceive bringing the most revenue,
Yep.
right? Boarding, ED crowding, everyone has it.
Yep.
And so what are the strategies that they're trying to do to decompress that? Because it's really disheartening when you walk in at 7 a.m. and you've got 55 beds and 70 boarding patients, right? You already start off negative. Substance abuse, behavioral in Texas, psych is one of the overwhelmingly negative issues going on right now for emergency medicine. Medical record documentation demands, I mean, that's something in geriatrics you can't really do to help them. So a lot of it that you want to, from my perspective, this question, this is probably a very important question. Kind of gives you an idea how well your leadership in the department is representing the needs of the department.
Yeah, I'd like to, to also take that opportunity to say, have you had any major wins in the department in terms of some of the issues that we're facing, and how did you get to that win? So then you can hear about, whether or not they had hospital buy-in, whether or not they had multidisciplinary interactions, how they got to where they were going. And then you can talk about what are some of your current issues and how could I help you get to where you want to go with that.
Yep. Cool. So this is kind of number 9 on the 13 questions. It's kind of related. It's just a little bit of a different and an easier way to ask. And this is not unique to medicine, but this is the usual, like, if you could change one thing about your organization, what would you change, right? Oh, you don't like that one? Oh, yeah. So I mean, it's a tough thing. You're putting the interviewer on the spot because you're asking he or she to now disclose something honestly that is a problem for them, and you're looking for, for kind of a insight, and potential solutions on the horizon.
Yeah, I mean, I think you hit the point. Everybody has warts, and you're asking them about their warts, and nobody wants to talk about their warts, right? So how do you ask a question about somebody? It's something that they're not proud of, but you really need to know, because if it's really bad, you don't want to come here and work, right? So I think if prefacing that question as I would anybody I was asking about their warts, to go, man, I got warts. Everybody has them. What are yours? Is kind of it makes it easier to tolerate when you're in the hot seat, so.
Yep.
What I was saying behind the scenes is somebody asked something similar to someone they were interviewing with, what's the weakest part of your program? And the response was the applicants. The one way to ask this question may be, what are the top 2 or 3 things that keep you awake at night as a leader of this department? And that might allow them to kind of start to go on. Well, right before I go to sleep, last thing I do is check Epic and see how many people are in the waiting room or what have you. And that might help tease out this question.
And one of the things this really highlights is this is probably the first time in your guys' careers that the tables are flipped, right? Because you were in the position before of people asking you that question. And there are going to be more jobs out there than there are graduates. And so you get to really ask the questions now and really make sure that you find the right fit for yourself. Unfortunately, depending on where you look, up to 50% of new grads change jobs within 2 or 3 years. So we're not doing a good job of asking those questions. So take that opportunity, because the roles at most places are reversed for you now.
But I love this question. I love getting it, right? Because I want people to know where our weaknesses are, because I don't want them to come in and think we bamboozled them and weren't honest. So if you're going to ask me this question, I'll tell you what my problem is. I'm going to give you a but or an and on how we're handling it. So I'm not going to tell you, I'm going to try to make it that we're trying to address it. But this is a great question to get. I mean, I'd rather tell somebody that, yep, we're boarding right now, and it's going to happen for 5 more months, till we open 20 more beds. So I like this question.
So I'm gonna also just kind of tell you some additional questions we did not get to, because I want you to see them and think about them, and also you can look these up on the SAEM website, the 13 questions. All right. Yes.
Before you do, how do you tactfully ask about transparency in terms of how a group is run, what are opportunities for advancement and promotion, and also compensation?
Yeah, that's a really good question. So number 3 on there is money, and all the stuff in green is really financial kind of questions that are super important. It's almost tough to just cover that in just this hour, so we kind of focused our work on the non-money stuff. But I'm gonna, since we have a little bit of time, I'm gonna open up and let you guys comment on that.
Yeah, it's a great question. It's probably a huge topic in and of itself, but I will tell you that, being 10 years out, the small differences in compensation are far less important to me than all the other things we've been talking about. That's really, you guys have hit a winning lottery ticket by getting into medical school and getting into emergency medicine residency. I think, taking a job simply because it's going to pay the most and suffering possibly, harder shifts or whatever it may be, my advice is it's not worth it. You take advantage of the winning lottery ticket you have and find a great fit for you.
Yeah, and how about, so that was a tough question and a big question. The transparency question, like, what should we expect? In terms of bonus, or in terms of who's paid what, or in terms of what, salary changes with time, cost of living, or, you just get more money because you've been there for 10 years, or like, how are they to sort that out from a fairness standpoint?
Yeah, I think that you're a professional now. This is a great question, and I think that you don't need to be embarrassed to understand that you're expected to do a job, and you should be compensated fairly for that job, okay? And so you need to understand how that compensation is delineated, how the group does its finances. You can ask those questions, and it shouldn't be embarrassing, or you don't have to be overtly tactful about that. I would just say, okay, help me understand the compensation package, benefits, and how we get paid, and how it's calculated, and how the group functions, so I can understand that, because I think that's important for me to understand. I don't think that's hard to ask, but on the point of what he was saying, I would echo exactly what he's talking about, that this is a question you need to ask. You need to understand this. You need to be able to compare the finances. But I think, for the most part, the residents focus a little bit too much on the financial side of this when they're interviewing for jobs. They get kind of steered into numbers so much that they lose sight of the really first question: what is the culture? What are the people? What is the job like? What is the workflow like? What is my life going to be like? That's more important than this, but all of it should be asked.
Yeah, and it's definitely something you need to know, and you can be very upfront about that. I would just recommend saving that for the end and asking the other questions first, because sitting on the other side of the table, the very first thing you're asking me about is compensation. That's a red flag to me.
Yeah. So number one was group at-large philosophy on physician wellness. That's a tough question, but it's important. We talked a little bit about number 3. Number 7 is kind of just the granular question of, am I an employee of a contract group or employee of a hospital or a hospital system or an independent contractor? I'm not going to get into that here. Another money question on medical malpractice and tail coverage. Another money question on who are you ultimately working for, which is kind of similar to the other one. And then this one I kind of like that we didn't get into. What are the unique ways your group or your department innovates or leads practice change in acute or emergent care? It's kind of big, it's kind of bold, but that's another one of the questions we did not get to. I planned it. I knew that we would not. I just want you to see these because I want you to be able to refer to them on the website. And it's possible in the year ahead with RAM's cooperation, we're going to dive into some of these a little bit more with some of these partners here. What amenities exist in the non-work related community that I'm practicing in? That's a lifestyle question, but is an important question. So that's it for the specific content. I want to just allow you guys to provide any just final observations, final thoughts. I'm going to allow anyone to have any final questions too. And then when we're done, we'll hang out here and be available. You can come and one-on-one meet any of us and ask us any other questions that you might have. Anyone want to do any wrap-up comments?
I think that the key is to ask the questions. I think sometimes you're intimidated. It's hard to ask that about finances and stuff, but they are important. But it's also really important to understand what you're doing. I think when you go into an interview, if you can get out of that what they expect from you and what opportunities for growth exist for you and how you plan to get there, I think that's a winning interview because you've then dealt with the future, the present, the future, and everything in between.
I think there's significant changes right now in emergency medicine. I think one of your best resources are previous graduates that you might have access to through either your program or other programs, just a few years out, because they'll be very near peer and can kind of tell you their perspective on when they joined and what it's like now and how much change there's been. So I think it is a changing landscape, though.
Just over the years, I've had some people do some really bad things in interviews. I had somebody drop the F-bomb in the middle of the interview, and I'm like, what? How would you do that? Come unkempt to the interview, not overtly intoxicated, but I think they might have been. And so just to kind of the basics, kind of put your best clothes on, be professional, be humble. That's what we look for, and that's what I look for in employees is humility because it prevents risk and usually drives great medicine. And then as far as job searching, do the hard work to find the job. I think a lot of residents just kind of take the job near them or it's easiest or I had a colleague go there. Do the hard work to, like all we're talking about. And it's work, and it takes time, and it takes effort, and it takes calling people, and it takes getting to know people, and it takes networking. And if you do the hard work, I think it's going to pay off. I think that's a true stat. Most people will leave after 2 years. I don't think they really want to. I think they just found a bad job. So, but I think that you guys, Travis made a great point. For the first time in your life, you've been just clawing over people, trying to get into med school, trying to get into residency, and now you need to realize that you flipped the script. Now they want you. And so it's time for you to evaluate and not show so much of yourself. You've always been in interviews trying to show how great you are and how awesome you are in your research and how smart you are. And it's now, you need to do a little bit of that, but really it's now time for you to flip it on them and ask these questions in an appropriate way and find out the right information.
Yeah, those are all great points. I don't have anything else really to add to the actual interview, but I just want to congratulate you all on getting into emergency medicine, on all of your upcoming graduations. Emergency medicine is a wonderful field to work in. Just understand there are difficult patients, there are difficult hospital situations everywhere. It's not just in your residency. I thought everything was going to be great as soon as I left. And turns out patients are patients. So learn how to accept and embrace what's happening around you, and just acknowledge and keep in mind how lucky we are to have this job, because it is a wonderful job.
Yeah, I really appreciate that. I want to also just thank the panelists. Collectively, these leaders have, literally interviewed thousands of people collectively over decades. And I'm really happy that they've been able to come and share their thoughts, their wisdom, their experience. And so with that, we'll close the session. We'll be available if you have any questions. But thank you very much for coming, and thank you to the panel.